Sir, could you please start?
Good morning. It's a pleasure to join all of you in Dhaka. I hope I am audible and the slides are visible.
Yes, sir.
Thank you. So, after two nice talks by Dr. Vijayaraghavan and Dr. Devika, we will discuss in the next few minutes about echocardiographic assessment of a prosthetic valve. Now, if you look at the criteria given for assessing a prosthetic valve dysfunction, whether it is a stenosis or a regurgitation, a lot of parameters will be copied from what is practiced for a native aortic valve or a mitral valve stenosis or regurgitation. Many of the parameters like assessment of the volumes, assessment of regurgitant fraction, every parameters will be more or less copied from native mitral or aortic valve regurgitation or stenosis. So rather than dictating out all the be followed for identifying a mitral stenosis or a mitral regurgitation or aortic stenosis or aortic regurgitation after a prosthetic valve, I want to show the challenges that we face in echocardiographic assessment of a prosthetic valve. And for that purpose, I'm going to take a different route. I'm going to start with a clinical patient example to illustrate the evaluation of a dysfunctional prosthetic valve. A 48-year-old gentleman who gets a closed mitral commissurotomy for rheumatic mitral stenosis in 2000. Then in 2012, he develops stenosis and mitral regurgitation needing a mitral valve replacement. His aortic valve slowly becomes dysfunctional in 2018. And ever since that third surgery was performed, he continues to have heart failure, edema, class 3 dyspnea. All these 2 years, the doctors who are examining him are finding evidence of anemia, mild jaundice, and red-colored urine. He was diagnosed as mitral paravalvular leak 1 year after the surgery. So, many of these symptoms were attributed to the mitral paravalvular leak, like anemia, jaundice, red urine, heart failure, edema. He undergoes a paravalvular leak mitral device closure in 2019, that is 1 year later. There was a transient relief after the paravalvular leak device closure for almost about 8 to 9 months, but then he recurs with again anemia, some amount of jaundice, and red urine. Now, if you look at, I'll go now systematically through his echocardiogram. This is the hepatic venous Doppler. He is in sinus rhythm, and there is systolic flow cells in the hepatic veins. IVC is dilated and congested, indicating elevated RA pressure, and systolic flow reversals in the tricuspid, in the hepatic veins indicate tricuspid regurgitation. This is the mild tricuspid regurgitation, mild to moderate tricuspid regurgitation. You can appreciate some amount of RV dysfunction, and the tricuspid regurgitation predicted RV systolic pressure is almost 4.5, which gives an RV pressure more than 90 or almost close to 100. So there is evidence of pulmonary hypertension. There is evidence of mild reduction in the RV contractility due to the hypertension, and there is evidence of mild to moderate tricuspid regurgitation. If you look at the left ventricle, the left ventricular contractility seems to be normal. Now, we look at the Doppler flows through the mitral valve. The mitral valve flow through the mitral prosthetic valve, we are having a peak gradient of close to 14 and a mean gradient of close to 8, which is not significantly elevated. So that means the mitral prosthesis function in terms of diastolic gradients are normal. And if you look at the systolic duration, during systole, there is not much of a mitral regurgitation. There is not a a pan-systolic mitral regurgitation is not present. So the quantum of mitral regurgitation is possibly not extremely severe based on the Doppler patterns. Now we need to understand one thing. If you are not seeing the mitral regurgitation on a prosthetic valve, that does not mean there is no mitral regurgitation. We need to understand that there is a process of acoustic shadowing by a metallic prosthetic valve. So whenever you are having a metallic prosthetic valve, it will produce a shadow behind the prosthetic valve. So if I am saying that I am using the left apical view, in an apical view, the mitral prosthesis will produce a shadow which will hide the entire left atrium. And so I may not be able to visualize the mitral regurgitation jet on the apical 4-chamber view. Looking at the left ventricular contractility, the overall contractility seems to be adequate. If we go by the LV strain pattern, the LV ejection fraction by Simpson's method came to about 64%. The longitudinal strain was about -30, mildly reduced. RV was more dysfunctional. RV strain was, the free wall strain was -8 to -9. So RV is more dysfunctional, possibly due to the significant pulmonary hypertension, which is a reflector of high right ventricular afterload. So now what do we have? We have completed the transthoracic echocardiogram. We have evidence of normal left ventricular function, normal mitral valve prosthetic gradients. Mitral regurgitation is present, but it is hidden by the acoustic shadow. There is significant pulmonary hypertension, and there is RV dysfunction. Now, because the patient is having an aortic prosthesis also, aortic prosthesis is also hiding the assessment. This is the aortic prosthesis, and the aortic prosthesis also hides the assessment of mitral regurgitation. So, because of this, the transthoracic echocardiogram has got a limitation now. So, what next? The next option obviously will be transesophageal echocardiogram. So this is a transesophageal echocardiogram looking at the bileaflet mitral prosthesis. Very clearly, the two discs are opening and closing appropriately. So that means the mitral prosthesis opening and closure is adequate. If you carefully look at the other features, there are some loosely mobile masses that are seen on the left atrial side. And if you go a little laterally towards the left atrial appendage, again there are some loose masses. Let us concentrate on the mitral valve movement. Appreciate there are 3 jets. All the 3 jets are laminar. All the 3 are uniformly blue in color, indicating that there is no significant obstruction. We will know that in every mitral bileaflet prosthetic valve, there are 3 orifices, 1 central orifice and 2 lateral orifices, and all the 3 orifices are seen here. So mitral valve disc mobility is normal. Now we were looking at some of the mobile masses on the other view. We can also appreciate this is the paravalvular leak device that was positioned in 2019. So we can appreciate there are some loose masses on the surface of the annulus, and these are the paravalvular leak devices, and so we can appreciate some sort of mobile masses on the top of the devices. So here we are putting the color over the previous paravalvular leak devices. So this is the paravalvular leak device. There is a small amount of residual flow that is seen between the devices, and posterior to the 2 discs, posterior to the 2 paravalvular leak devices, there is some more mitral regurgitation, and here there is a loose mass that is floating on the surface of the devices. So the information that we have till now, there is some amount of leak through the device, there is some amount of leak posterior to the device, so this is also paravalvular. The valve function is normal. There are some abnormal loose mobile masses on the surface. So now concentrating on the mobile masses, there is a mobile big mass over the annular region, and in the region of left atrial appendage, there are multiple tiny masses. And if you look carefully on the color flow, there is a jet that is hitting over those areas of the appendage, and corresponding to that, there are multiple small masses. So now is our question. We have identified that there is a significant posterior paravalvular leak behind the two previously placed devices with multiple abnormal masses, loose mobile masses. So now what are the possibilities? We have normal LV contractility, we have normal mitral valve leaflet motion, we have two previous paravalvular leak devices, and posterior to these two paravalvular leak devices, there is a posterior severe paravalvular leak. There are loose mobile masses over the paravalvular leak devices in the region of left atrial appendage. The mitral antegrade flow is normal. Mitral valve prosthetic opening and closure is normal, associated by the significant paravalvular leak MR. So MR is present. Now the questions are, what is the explanation for the loose masses? Now we go back to the history. There is anemia, there is jaundice, there is red urine, there is dyspnea, there is edema. All these things are going for 2-year duration. Now, option 1, infective endocarditis. Infective endocarditis can produce anemia, jaundice, red urine, dyspnea, edema, and loose multiple masses. But this is going on for 2 years. He has not been treated with any antibiotics. So 2-year duration is against infective endocarditis. So then, is it all these symptoms are due to paravalvular leak? Possible. Anemia can be due to paravalvular leak, jaundice due to paravalvular leak, red urine paravalvular leak due to hemolysis, dyspnea, edema, everything can be due to paravalvular leak. But whenever there are multiple masses that are mobile, we always think about infective endocarditis. So the next step is, we do some investigations. The hemoglobin is 8.9, anemia, urine shows plenty of RBCs, plenty of WBCs, and the culture grows gram-negative bacteria. If it is a glomerulonephritis due to infective endocarditis, the protein will be high. Here the protein is not there at all. The bilirubin, if in urine, will show hemoglobinuria in paravalvular leak and not hematuria. Hematuria is a feature of not of paravalvular leak. Bilirubin, contrary to what we anticipated in the hemolysis, it is all direct bilirubinemia. It's not indirect. So direct bilirubinemia means, what does it indicate? It indicates that the patient is having congestive hepatomegaly and liver dysfunction causing bilirubin rather than paravalvular leak hemolysis causing bilirubin. Urea is very high, creatinine is very high. ESR is normal, C-reactive protein is normal, fever chart is normal. The patient has never received antibiotics for 2 years. So the features of normal ESR, normal C-reactive protein, normal, no fever, all indicate that it is very unlikely that this is an infective endocarditis. So it is possibly a paravalvular leak causing heart failure. Along with that, the culture being positive, RBC being positive, all are possibly explained by a chronic urinary tract infection of significance. His medications are torsemide, spironolactone, beta blockers, hematinics, and warfarin. None of the medicines are actually nephrotoxic except a high dose of diuretics may lead to renal insufficiency. So now the C-reactive protein, no fever, and 2-year duration all indicate against infective endocarditis. The red urine is hematuria, not hemoglobinuria. If it is hemoglobinuria, then paravalvular leak induced hemolysis is possible, but this is hematuria. Bilirubin is direct, indicating liver congestion from right heart failure and pulmonary hypertension. So between the differential diagnosis of infective endocarditis versus paravalvular leak, we want definitive answer on the masses. So the next step that we do, go for, we look at in transesophageal echocardiogram, an explanation for the abnormal large mobile masses over the two paravalvular leak devices and the small multiple loose masses that are present in the left atrial appendage, and more information about the paravalvular leak. So now we go for a 3D echocardiogram. These are the two paravalvular leak devices. One device here and second device here with the mitral prosthesis here. The prosthesis movement is normal, good bileaflet valve. This is the mobile mass over the device. Now, if you carefully look at this mass is strict rectangular mass, which means this is one of the surgical pledget that has been used by the surgeon. A vegetation will not be a strict rectangular mass like this. So this is a surgical pledget that we have been interpreting as a possible mobile mass. Now we have to interpret what are the tiny masses that are present in the left atrial appendage. We now have an explanation for this large mass. Now there are multiple small jets. And so these small jets, if you look at the residual leak between the device, it is skirting that area. And so these are all possibly jet lesions rather than an infective endocarditis. Now, if you carefully look here, these are the appendages. The two discs are seen. There is a small amount of and that paravalvular leak is causing the jet lesions. These tiny masses are possibly not infective endocarditis. And you now quantify the paravalvular leak. These are the two devices. And on a 3D echo, there is a posterior third significant leak, which looks like we may be able to plug this also. Now, it is very important before putting in an additional device to exclude endocarditis. And now we are convincingly excluding an endocarditis because this mobile mass is strictly rectangular in shape, which is a surgical pledget. And all the tiny masses that we found on the left atrial appendage are due to jet lesions. And so now we have an explanation that this patient is possibly not having infective endocarditis. It is safer to go in and put in additional paravalvular leak devices, and infective endocarditis is to a large extent excluded. Already we have negative cultures, we have normal ESR, normal C-reactive protein, and absence of fever for the entire 2 years. And on the top of it, now we have an evidence. Whatever we saw as a mobile mass is all having an explanation. One is a surgical pledget, and the tiny masses that we found on the left atrial appendages are all due to the jet lesion hitting against the left atrial appendage, causing endothelial abrasions and producing tiny masses. So now the final diagnosis for us, post double valve replacement, post paravalvular leak device closure 1 year ago, there is persistent severe pulmonary hypertension. There is significant RV failure and congestive heart failure, which is causing hepatic congestion and direct bilirubinemia. Heart is causing edema. The heart failure, the paravalvular leak is causing dyspnea. The red urine is due to hematuria caused by an urinary tract infection, and it was not due to glomerulonephritis due to an infective endocarditis. There is fairly a significant posterior paravalvular leak. These are the two previous devices. This is an anatomical surgeon's view. So anteriorly is the aortic valve, this is the mitral prosthesis, and this is posterior. And the loose mobile structures that we saw are pledgets or jet lesions. This is a pledget, and what we saw here were jet lesions. Now, we are convinced that there is no infection and all the pathology is due to paravalvular leak. So, what did we learn from this case presentation? Evaluation of prosthetic valve is far more complex compared to a native valve. You have a lot of acoustic shadowing which are going to hide a large portions of the heart. Assessment of a native aortic valve and a native mitral valve is not equal to assessment of an aortic prosthetic valve and a mitral prosthetic valve. So much of echogenic structures, so much of surgeon-induced sutures, pledgets, all of them will be there, and they will alter. Loose mobile masses cannot be considered as infectious just because they are mobile, but they have to be factored in. We need to understand the issues created by acoustic shadows. A significant mitral or aortic regurgitation may be hidden by the acoustic shadow. We have to understand different valve designs, and based on the valve design, what is its opening and closing. We have to understand the altered anatomy that has been created by the surgery and a different set of hemodynamics compared to native valves. If it is a bioprosthetic valve, depending on the age of the bioprosthetic valve, the acceptable gradients will vary. And if it is a mechanical valve, depending on the nature of the mechanical valve, the gradients will vary. whether it is a ball and socket valve, whether it is a bileaflet valve, whether it is a single leaflet valve. The routine tricks of diagnosing infective endocarditis may cause not only overdiagnosis but also underdiagnosis. So a careful, comprehensive clinical examination and imaging is vital. So prosthetic valve is a challenge for a clinician. Now coming back to the topic, the problems that occur after a prosthetic valve that we need to look at immediately after the surgery will be paravalvular leaks. We saw an example. Thrombosis of the valve leaflet causing immobility of one of the leaflets. Low cardiac output state, which can be due to a reason completely independent of the prosthetic valve due to the ventricular dysfunction. Infective endocarditis can happen very early, and patient prosthesis mismatch, which is a higher gradient for a given prosthetic valve. All these may manifest immediately. Late after surgery will be structural valve deterioration. As the valve gets older and older and older, some of these mechanical valves show some amount of degeneration, and biological valves show far more degeneration. Thrombosis, bleeding, pannus formation, regurgitation, which may be valvular or paravalvular, infective endocarditis, patient prosthesis mismatch, chronic hemolysis in mechanical valves, and sometimes pseudoaneurysms in the subannular area. All these will be problems after prosthetic valve. The possibility that you will have some sort of event after a valve replacement is quite high after any prosthetic valves. So if you track the patient for about 15 years after a valve replacement, you have a substantial amount of problems that will come one after the other. It may be valvular, paravalvular regurgitation, it may be structural valve failure more and more with bioprosthetic valves, it may be endocarditis, it can be embolism. Valve thrombosis is the nagging problem of a mechanical valve with an incidence of close to 1% per year. It is high in mitral and tricuspid valve and less in aortic valve. Often attributed to be due to inadequate oral anticoagulation. It happens even with adequate oral anticoagulation. Contrary to our expectation, some of the onset may be gradual. There is a single bileaflet valve with one leaflet moving well and the other leaflet is in closed position. The gradients may not be high and these patients may have a gradual presentation. So the clinical presentations can vary from being an incidental finding or a peripheral embolism from a thrombus, or truly present with stenosis or regurgitation and gross heart failure. Transesophageal echocardiogram may be able to show informations like whether it is a possible thrombus or pannus. However, it is difficult to differentiate the two categorically. The very fact that acute or subacute presentation alone cannot differentiate between thrombus and pannus is because if there is a bileaflet valve and one leaflet is fully mobile, the gradients will be normal for a long period of time and the patient may not have a symptom at all. So just by the history of acute versus subacute, and acute means I will go for a thrombolysis and subacute means I will go for a surgery, does not hold good. When we see the patient acutely, it just means that the previous leaflet was closed for 1 year and the second leaflet got closed for the last 3 days. So it is not so easy to differentiate between prosthetic and pannus. The recommendations that are given for a valve is fluoroscopy to confirm the valve abnormalities. Whoever is very sick, like class 3 or class 4, or any patient who is because thrombolysis in these patients carries higher mortality. Whereas if a patient is relatively stable, then you can try a thrombolysis. While this is the recommendation given for the Western world, in countries like ours, a fair number of patients, even those who are class 3 or class 4, and a fair number of patients who have a reasonably large surface which thrombus that is seen, also get thrombolyzed, sometimes rather effectively. And so institutional practices and local factors will determine on this management rather than American or European guidelines. Valve structural degeneration is
Sir, 1
another
minute
problem
left.
yes, sure. Over a period of time, the valves degenerate, and this is a normal mobility of a bileaflet valve, but you are having leaks across all the closure points. So structural degenerations do sometimes occur. Paravalvular leaks can occur after any type of valve. This is a biological valve with a paravalvular leak. This is a mechanical valve with a paravalvular leak. We have already seen the paravalvular leak's significance. We need to differentiate a paravalvular leak from a dehiscence. What is a dehiscence? A dehiscence is defined as a larger than 20% of the circumference being ripped off. So a paravalvular leak is something that is localized. A dehiscence is something that is more than 20% of the circumference. Infective endocarditis is another problem. Very often we'll need a transesophageal echocardiography because smaller vegetations may not be identified. This is a bioprosthetic valve with a vegetation, and that is seen far more clearly on a transesophageal echocardiography. Periprosthetic root abscesses may be seen as endocarditis progresses, and these root abscesses indicate more and more damage on the structure of the annulus by the infections. So, in short, one tip that I can tell for the listeners, prosthetic valve assessment is a difficult challenge. One of the way in which you can do a proper assessment will be to do what is called fingerprinting your prosthesis. The moment the surgery is done, you call the patient on the 7th day before discharge and take a fingerprint of the patient. What is a fingerprint? Different echocardiographic views in apical four-chamber, parasternal, and study take a picture about how the valve looks and in which view you are getting the leaflet separation best, what is the basal gradient, and so that becomes the fingerprint. Each time this patient comes to you again and again, you compare with the original fingerprint. My previous gradient was 12 by 8 and today it is 28 by 20. So this is clearly abnormal. So compare with the fingerprint. So fingerprinting of a patient is the crucial way of assessing a prosthetic valve. Summary of prosthetic valve problems. Prosthetic valve leaflet has to be differentiated from dehiscence. A thrombus versus pannus is difficult to differentiate. Infective endocarditis may progress on to root abscesses and we need to evaluate them. We have to understand that structural valve degeneration occurs over a period of time, not only in biological valve, which is expected, but also in mechanical valve. Patient prosthesis mismatch is a problem wherein a smaller sized prosthesis leads to higher gradients and rarely pseudoaneurysm. Analyze the prosthesis by studying the nature of the prosthesis, fingerprint them, assess their hemodynamics, and look at their comorbidities. Echo is crucial in diagnosis, but interpretation is difficult and needs experience. Thank you very much for your attention.
Thank you, Sivakumar sir, for your brilliant presentation. Echocardiography of prosthetic heart valve remain a challenging issue for our new generation, and we have definitely learned a lot from your presentation. Thank you, sir. Now I would like to move towards our moderator, Professor Tuhin Haq Madam, to discuss about the session and conclude the question answer session. Thank you, madam.
Thank you, Dr. Tamina. And I'd like to congratulate all the speakers for their nice presentation. Professor Vijay Raghupan nicely pointed out, and by showing the important cases, how we should concentrate on each case to avoid the pitfalls. His presentation was very brilliant, and each fellow should concentrate on individual cases to avoid the pitfalls and concentrate on each imaging modalities and correlate the clinical findings so we can avoid the pitfalls. Dr. Devika Chatterjee was very excellent in pointing each practical steps for evaluation of LV systolic as well as diastolic function. His lecture was very clear, and to tell the truth, her lecture about diastolic function was very clear and it was easy to understand for each fellows. So I like to congratulate her very much. And for the last speaker, I really, he is great. And we all know that echocardiographic evaluation of the posterior valve is a real challenge. And he opened up our mind how to repeatedly concentrate on echo findings and how to repeatedly correlate the echo findings with the clinical findings. So we can finally reach the accurate diagnosis. But it's really challenging, and we have to fingerprint, as he mentioned, we have to fingerprint the prosthetic valves and very careful for evaluation of the prosthetic valve evaluation. And echo is crucial. And when transthoracic echocardiography is inadequate, we have to take help of transesophageal echocardiography. And finally, 3D will help. So congratulate all the speakers. And now the floor is open for discussion. But I see there is no question answer. There is no question in the question box. So I like to request if there are any panelists who have any comment or question to our speakers. If not, then I would like to request our chairpersons if they have any comment for the speakers.
Professor Tuhin?
Yes.
This is Dr. Khalid Mohsin. I'd like to thank all the three speakers, particularly their topic is very relevant in the field of adult echocardiography. Though I know that Dr. Sivakumar is a very dedicated structural interventionist and is a very dedicated pediatric cardiologist. I have a question to Dr. Sivakumar that regarding the post-operative assessment before discharge, this echocardiography should be only a transthoracic echo, or it should be included, the transesophageal echo should be included in the baseline follow-up of the patients, number one. And number two, in some patients, in the pediatric patient, before their physical growth is completed, if we replace a valve of this group of patient, what are the chances of a valve outflow tract mismatch or valve patient mismatch, and what will be the management of in this group of patients?
Thank you, Dr. Mohsin. Two questions. Number one, about what sort of modality of echocardiography in the post-operative assessment. It has become a conventional practice in all the units that are doing a valve surgery to have an intraoperative transesophageal echocardiography to assess the seating of the valve, a completion of the sutures, absence of paravalvular leak, and presence of normal prosthetic valve mobility on table itself. So that transesophageal echocardiography, if the surgeon is satisfied, he is going to decannulate from cardiopulmonary bypass and come out, and that echocardiogram is sufficient. There is no need to repeat another transesophageal beyond the time when the intraoperative TE was done. But what I was telling was, on the 7th day or 8th day when you are discharging, you do a transthoracic echocardiogram. The patient, each time he is going to come back to you with a fever where you suspect infective endocarditis, with a heart failure where you suspect a prosthetic valve thrombosis or a prosthetic valve regurgitation. The question is going to be addressed initially by a transthoracic echocardiogram. So you should have a baseline fingerprint on transthoracic echocardiogram. Having observed many single leaflet and bileaflet mechanical valves in various locations, you would have observed that some valves mobility is better seen on a parasternal long axis, some are better seen on an apical, and some are better seen on a space between the parasternal and the apical. So during your echocardiogram, in the fingerprint that you are making, you have to mention that this patient's prosthetic valves 2 leaflets are best seen on a parasternal short axis view. So now the next person who is going to see the patient when the patient is coming sick with breathlessness, and where you are going to differentiate between a pneumonia breathlessness versus a mitral valve thrombosis breathlessness, the next guy is going to use that standard platform, parasternal short axis. And here now he notices that instead of 2 leaflets that are moving, only 1 leaflet is moving. So it is easier for him. So a fingerprint on the 7th day. Why not earlier? As you do it earlier and earlier, there will be some amount of sinus tachycardia caused by anemia, operative pain, lung collapse, variety of problems. The sinus tachycardia settles and the patient gets his baseline heart rate at the end of around 7 to 8 days, where your gradients mean a lot. On the contrary, if you are doing it on the first or second postoperative day when the heart rate is 130, the gradients are much higher, and that cannot be the baseline for comparing your gradients. So it is best done on the 7th or 8th day when the patient is fit for discharge. And moreover, every parasternal view in a postoperative patient is painful, and the pain subsides better and better on the 7th day. The chest wall edema becomes better and better on the 7th day, and your pictures quality, the echo windows improve around 7th day. So fingerprinting is done on the 7th day. Now coming to the second question of pediatric children going for a valve replacement and getting a smaller valve, and then as they grow older and older, whether they will get into patient prosthesis mismatch. Yeah, it is a small possibility. Having said that, the patient prosthesis mismatch is more talked about by echocardiographers as a theoretical possibility whenever you are having a higher gradients, and most of the higher gradients are attributed to a patient prosthesis mismatch. But in many of these patients, when you take them into the catheterization lab and put a catheter on either sides of the chamber, you will find that the amount of gradient may not be significant. The patient prosthesis mismatch is a relatively less commonly seen entity in our populations. The reason is the structure of our patients are much smaller, and we do cope up even with a 17 millimeter or a 19 millimeter aortic valve, and similarly a 21 or a 23 millimeter mitral valve far more efficiently compared to a 110 kilogram American who has got a body surface area of 2 square centimeters. So while we talk a lot about patient prosthesis mismatch, we talk a lot about higher gradients being attributed to PPM, very often in true clinical practice, PPM is not such a common entity. Now, the question that will come very often in the aortic valve will be, I keep getting a very high gradient. A mechanical prosthetic valve in the aortic valve is supposed to give you gradients that are very less, something like 20 by 10, 22 by 10, 21 by 10, nothing more than that. But in the contrary, you will find a patient who is having 50 by 30, 60 by 30, and very often you will put that into what is called patient prosthesis mismatch. In fact, you will recognize that in native aortic stenosis there is a principle of pressure recovery, and pressure recovery is a phenomenon wherein there is a much higher gradient that you will be noticing across the valve during echocardiography. But when you put in catheters between ascending aorta and left ventricle, the gradient would have reduced. The pressure would have recovered in the ascending aorta. This pressure recovery phenomenon is also distinctly observed in every aortic prosthesis. And so when we are having a slightly higher gradient across the aortic mechanical prosthesis, if we know for certain that the leaflet mobility is completely normal, we can say that the higher gradient on echocardiographic report, we may put it as patient prosthesis mismatch. But if you go for a true hemodynamic check, the amount of gradients that you are getting on echo Doppler. So I would like to say that a large number of higher aortic valve gradients after aortic valve replacement in the mechanical valve is caused by some degree of pressure recovery, and not truly in every patient it is due to a patient prosthesis mismatch. And hemodynamically, there will not be significant gradient in a majority of the patients. A small minority may have PPM, but a large majority will not have PPM despite a higher gradients that you see on an apical 4-chamber, especially in aortic prosthesis.
Sir, I have a question, sir. Sir, thanks for your excellent talk. My question is, if there is LV dysfunction in case of adult patients, sometimes there is LV dysfunction. So how I will assess the severity of the prosthetic valve gradient if there is LV dysfunction?
Dr. Naveen, thanks for this question. And in all the hemodynamic numbers, that means stenosis severity, regurgitation severity, all the informations that are applicable on a native valve will be copied onto a prosthetic valve. There is nothing that is specifically mentioned for a prosthetic valve. If you are having a low gradient due to severe LV dysfunction in an aortic stenosis, the same low gradient will be there in an aortic dysfunctional prosthetic valve also. That is one of the reasons why I did not like put tables after tables to identify what is normal mitral mechanical valve and prosthetic valve. All these are primarily cut, copy, paste from a native aortic valve. So most of the hemodynamic, in fact, there are lots of subtleties in this. For example, some people will say pressure half time, that your standard acquisition of a mitral valve assessment in a patient with a native mitral stenosis is also applied in a large number of mitral prosthetic valves. There are people who will say completely against it. There are people who will say that is an acceptable method. And in fact, there are people who will give a mitral valve area of 1.8 based on pressure half time also. There are some people who will say the pressure half time in a prosthetic valve does not mean anything. So what I'm telling is a large number of this data are just extrapolated from native valves, and they do not hold any substantial hemodynamic checks. So any numbers that you say, that stenosis gradient, regurgitation severity, flow reversals in the aorta, flow reversals in the pulmonary vein, all these parameters are extrapolated from native valve regurgitation. The gradients are extrapolated from native valve stenosis, and nothing specific for a prosthetic valve more.
Thank you, sir.